We'll just give everybody a couple of minutes to get in, okay? So I just see their numbers are coming up there nicely. So you're all very welcome. Okay, just give a few more minutes and then we'll get started, okay? Okay, you're all very welcome. Good evening and welcome to Arthritis Ireland's webinar for Fibromyalgia Awareness Day. You're all very welcome. Hello. My name is Martina Blake. I'm Services Manager with Arthritis Ireland. And for those of you that may know, Arthritis Ireland is the national charity for arthritis and associated conditions, of which fibromyalgia is one. So we're really delighted to welcome you all here tonight. It's been a couple of years since we did a fibromyalgia event. So the last one being in person when we were able to do that. But we decided to run a webinar tonight as part of our Awareness Day and supports for people living with fibromyalgia. And we're delighted to see so many of you able to attend tonight. And just to remind you that if your connection drops out or anything, the webinar is being recorded and will be available on the Arthritis Ireland website. We have an incredible lineup of speakers tonight, and we're really delighted to have the speakers that we do have. We have Dorcas here. Give a wave, Dorcas. Dorcas is a CNS, a clinical nurse specialist with a specialism in rheumatology and an absolute passion for all things fibromyalgia. So she's going to start off our event tonight with an overall view of fibromyalgia and what's happening and the clinic, the nurse-led clinic that's delivered there. Then we're following up with Louise Moore, and Louise is an advanced nurse specialist in Harold's Cross as well, with a specialism in rheumatology and pregnancy. So we're going to have an overview of women and fibromyalgia and hormones in pregnancy, and we'll try and touch into menopause or perimenopause, but we could be here all night, so it really will be a brief on that. And just that's the first part of our webinar tonight, is Dorcas and Louise, and then we're going to have a Q&A after that. And then the second part of the webinar is our final speaker of the evening, Caroline Martin. And I'll speak more to you about Caroline whenever we are ready to start with Caroline at about 8 o'clock. So we have Peter here as well from Arthritis Ireland. He's our tech support in case we need him. So that in case you're wondering why he's there too. So in the meantime, can I just remind you all to look after your own health conditions. None of you are on camera, so you can do whatever you have to do to keep you right. Stand or sit or stretch or drink your tea or whatever it is. And hopefully, you can relax and enjoy your event this evening. As I say, there's questions and answers there at the bottom of the screen, the Q&A and the chat function. So if you have any comments or questions, I'll be keeping an eye on them, and Peter will be prompting me with them as well. So we'll have our Q&As after, okay? So for now, I am going to invite Dorcas to speak first, okay? Thank you and enjoy.
Hello, everyone. Thank you, Martina, for that introduction. I will try to share now. Hopefully this works. And, I knew this would happen.
No, you're okay. It started. It's all good.
Okay, I'm trying to do a slide.
You go into the slideshow there at the top.
It's just, I can't see it because just trying to remove this bar that's over it. Okay, I have it, I think. Okay. Now, can you see it okay there?
Yeah, it's working fine. Thanks, Dorcas. Yeah.
Perfect. Thank you so much again, and thank you for everyone who has tuned in to listen to this very interesting talk about fibromyalgia. I feel really honored to be asked to speak at this special Fibromyalgia Awareness Day. My own awareness of fibromyalgia began more than 15 years ago when I started working as a staff nurse in a rheumatology ward. And I remember listening to many heartbreaking stories from female patients who had fibromyalgia and how it had impacted their lives, their relationships, and their careers. I even used to think fibromyalgia only affected women at this stage, and this made me feel even more determined to find out more about it and about what made it so difficult to manage. I'm hoping the allocated time frame will allow me to give you a brief overview of what fibromyalgia is, examples of its presentation and how it is diagnosed, and finally the recommendations, treatment, and management of fibromyalgia. I guess the overarching aim of this presentation is to increase awareness of fibromyalgia and how it impacts not only on individuals and their families, but also the community and the healthcare system. Current treatment options will also be explored. So there are many definitions in literature of fibromyalgia, and this one by Clore states that it is the most common cause of chronic, widespread musculoskeletal pain, often accompanied by fatigue, cognitive disturbance, psychiatric symptoms, and multiple somatic symptoms. And these symptoms may include such things as headaches and mood changes. So I have listed here a few facts about fibromyalgia, really. And I'm sure many of you will agree that fibromyalgia is a poorly understood condition, very difficult to diagnose and to manage. Even though fibromyalgia cannot be cured, thankfully, it is not life-threatening. However, people have to learn to manage their symptoms. It is not uncommon for people to spend many agonizing years attending different doctors and specialists before a diagnosis is finally made. And this is why it is important for clinicians to be more aware and knowledgeable about fibromyalgia to ensure early diagnosis and treatment. There is a lot of theories out there, beliefs and assumptions about fibromyalgia. And this is mostly due to lack of understanding of the condition. In actual fact, fibromyalgia is linked with a multitude of different types of symptoms that affect individuals in many different ways, some of which are listed at the bottom half of that slide. And you can see there, these symptoms like joint stiffness, these cramps, dry mouth, cognitive impairment. So it can be anything really, and it can affect people differently. This slide is just another illustration of how much longer it takes to get a fibromyalgia diagnosis. As you can see, compared to other chronic conditions, fibromyalgia can take an average of up to 6 or more years, while other conditions, chronic conditions, take 3 years or less to get a diagnosis. And even though this graph is from 2006, the trend is fairly more or less the same today. Fibromyalgia is a common worldwide condition affecting up to 6% of the population and in all ethnic and socioeconomic groups. It is 5 times more common in women compared to men, and actually other literature say it is 6 times more common in women than men, and also in people aged between 35 and 50 years of age. And therefore, women and people of that age group are at risk of developing fibromyalgia. In addition, also at risk of developing fibromyalgia are people with a family history of the condition, also traumatic life events, and people with inflammatory conditions. All this can also increase the likelihood of developing fibromyalgia. So what causes fibromyalgia? It is not known why people develop this condition. However, there are factors such as physical injury or emotional stress that are known to trigger the symptom. It is believed that a disorder in the central nervous system in the brain causes magnified pain perception in people with fibromyalgia. Now, if this abnormal pain perception persists, or if this pain processing persists, which is abnormal, it eventually causes disturbed sleep, mood changes, fatigue, and other symptoms. Fibromyalgia symptoms can overlap with many other conditions. This is one example of overlapping symptoms between fibromyalgia and only one other chronic condition, rheumatoid arthritis. And you can see here that both conditions can actually cause depression. They can cause symmetrical pain patterns. They can cause fatigue. I think it is safe to say that most of you with fibromyalgia can describe fibromyalgia symptoms better than anyone. However, I have these examples here of fibromyalgia symptoms that are more common. So you can see here, those in red are some of the main symptoms, such as chronic pain, fatigue, headaches. Then there's the secondary symptoms in blue, for example, irritable bowel, morning stiffness, swelling. And finally, you find other people also having other symptoms like sensitivity to cold, sensitivity to noise, and cramps. And symptoms, as you can see here, can affect people from head to toe. So it can be anywhere in the body. And it can affect them in many different ways. And really the key to managing these symptoms is education, it's developing self-management skills, and most importantly, a positive mindset. So pain is the hallmark feature of fibromyalgia, and it has the biggest impact on people with this condition, resulting in depression, anxiety, poor quality of life, and work disability. One of the worst cases that I have come across over the years was a young woman aged around 30 who couldn't tolerate normal human contact such as hugs from her young twin boys due to widespread pain and tenderness. Each time her toddlers ran toward her to give her hugs, she was left in agony and in tears. And we tried different therapies for this young lady and different type of medications, and nothing seemed to help. Until finally, even though she was afraid of water, she tried hydrotherapy. And that's when, and this is in her own words, she got her life back. So really, with fibromyalgia, it's usually trial and error, trying to see what works best for you and what works better for the symptoms that you have, so you can have a more normal life. How is fibromyalgia diagnosed? So there are no tests to diagnose fibromyalgia. Diagnosis is based on patient's comprehensive history and physical examination. Tests can be carried out to exclude other conditions that are presenting similar to the fibromyalgia. There are different diagnostic guidelines that are available, such as the American College for Rheumatology and European League of Arthritis, and they all involve evaluating pain, fatigue, and other symptoms. The EULA guidelines recommend that first-line approach to treatment of fibromyalgia should be therapies that do not include medication. If these therapies are not effective, then medication can be introduced as needed by the individual in combination with non-medication therapy. These are some of the examples of non-medication therapies, and there is strong evidence that cognitive behavior therapy and exercises are most effective for managing fibromyalgia symptoms. This is because developing effective self-management skills depends on successful behavior change. Cognitive behavior therapy is based on positive thinking and therefore helps with mental health and well-being. Partaking in regular physical exercises also improves your mental health and mood, and as well as pain. These are some of the most common drugs used to manage fibromyalgia in situations where non-medication therapies have not been successful. For example, antidepressants such as amitriptyline and duloxetine, used to improve sleep, reduce pain and tenderness, improve muscle stiffness, as well as anticonvulsants like pregabalin or gabapentin that are also used to reduce pain, and then opioids and non-steroidal anti-inflammatory drugs are also used, although there is no strong evidence for some of these medications, especially the opioids and the non-steroidal anti-inflammatory drugs. But they may help individuals cope with pain, especially people with other chronic pain conditions that may be making the fibromyalgia pain worse. This is a snapshot of the nurse-led self-management pathway I developed for our patients in Our Lady's Hospice and Care Services. It is a structured program spread over a period of 12 to 26 weeks. And one of our main recommendations is for patients to undertake online or face-to-face Arthritis Ireland courses that are offered through self-management program that they offer. This program is simple but effective, patient-centered, and we work with multidisciplinary team members as well, such as physiotherapy and occupational therapy. And this program really is, it can be replicated in any other centers around the country. And I feel it's really effective for developing self-management skills for patients with fibromyalgia. These are some of the services provided by the nurse in the fibromyalgia clinic. And even though no miraculous therapy exists, I do believe that knowledge is power, because in my experience, the more a patient knows about their condition and how their body responds to it, the more successful they are in managing themselves. COVID-19 pandemic had a huge impact on everyone, including worsening of chronic illnesses. In particular, the increase in stress and social isolation, especially for fibromyalgia patients, resulting in depression and poor sleep pattern. And there's also new evidence that COVID-19 pandemic has caused a rise in new cases of fibromyalgia. To me, the image on the left describes people living with fibromyalgia because they tend to look very well and healthy on the surface. and yet there's a lot happening underneath. I'm sure most of you agree with that. However, despite this, most people are able to work and to continue with normal activities, even though they may be living with chronic pain, fatigue, and so many other symptoms. There's no doubt that working with healthcare providers to understand and manage symptoms effectively with a strong family and social support can help improve and maintain your quality of life. Thank you so much for listening.
Okay, thank you, Dorcas. And that's a fantastic introduction to the whole area of fibromyalgia. So thank you for that. And it's fitting nicely in with, the theme of this year's Fibromyalgia Awareness Day, which is and people not understanding the pain and somebody looking so well, or, being affected by cold or heat. And then also the knowledge. And then I suppose it's the communication between the person living with fibromyalgia and the families and the people around them. So thank you so much for that. I'm seeing the parts on the screen, so I think you're getting well received there too, which is lovely. And so for now, I'm going to hand you over to Louise. And as I say, Louise is going to focus on women and pregnancy and all things women's health and fibromyalgia. So thank you, Louise.
Sorry, now can you hear me?
Yeah.
Okay. Oh gosh, and this did work, everybody. This, I'm telling you, this worked earlier today. Can Martina, can you share my slide, please? I don't know where everything has gone. Zoom. Can you hear me, Martina? Share screen.
You sure can.
Yeah, okay. Just apologies. We did a check earlier this afternoon, and everything did work. But that's maybe because I'm at home now. So thank you so much, Dorcas. You have really set the scene for us all. I really enjoyed your presentation, and it leads and has been very much the groundwork for what I'm going to talk about. So I have been asked to speak to you about fibromyalgia, and I suppose focusing a little bit on women's health, because I understand that's an area where people have lots and lots of questions, and I'm happy to share sort of, my experience with you. Now, before I continue, can people hear me? Can Martina, can you hear me? I put on earphones, so I'm hoping that might be better.
Yeah, we can hear you. All
Perfect.
loud.
Lovely. Okay, so just as Martina said, I work as an advanced nurse practitioner in rheumatology, and I'm in rheumatology 28 years. And like Dorcas, throughout my career, I've met lots of patients with fibromyalgia and absolutely understand the impact it has on their day-to-day life. My interest going forward, I suppose, my interest for the last 10 years has been very much focused on reproductive health, on women who are planning pregnancy and who are going through pregnancy, and also in that postpartum period. So I like this slide because it actually sort of gives us a little bit of focus about where we are sort of in caring for women with chronic disease. So again, if you see on the diagram, you can see sort of the late teenager, the young mom, the older mother who's continuing to work, look after her kids. And I very much see that our care in rheumatology is starting to become more focused on different life stages. And, we have a young adult clinic and a transition clinic. So I think probably as we go forward, I certainly hope and expect that our care for women is certainly going to improve from a rheumatology perspective. So next slide, please. So a little bit like what Dorcas has previously mentioned. So I did, when I was preparing for this a talk, I had a look at the most recent literature, and my experience of fibromyalgia and reproductive health has been that there hasn't been lots of information about fibromyalgia and pregnancy. However, you know, a common question or a common comment, I suppose, that we get in the clinics on a regular basis is that women will certainly say that, you know, that there's arthritis symptoms, whether that be inflammatory arthritis or whether that be fibromyalgia, are definitely worse around the time of my period. So that I sort of said, well, right, well, we have to sort of look into this and sort of think what's coming up. So there, again, not a whole lot of studies. This is a particular study that goes back to 2011, and it focused on women who had a SLE, rheumatoid arthritis and fibromyalgia. There was two parts to the study. Part one, women were asked to fill out a 100-day diary log, and then part two was a mailed questionnaire. So the fibromyalgia women cohort did not take part, seemingly, in the 100-day diary log. However, they did take part in the questionnaire piece. And it's quite a small study when you're trying to sort of get an idea of what's going on. There was only 61 participants. And from a fibromyalgia perspective, of that 61, 33 were on oral contraceptives. And of the women that were left, about half of them experienced a flare of their disease when they were not on their oral contraceptive pill. So again, you know, this study, there was some suggestion and there was some limitations to this study. In this was there possibly could have been some recall bias. However, there did seem to be some menstrual cycle flare in fibromyalgia. Next slide, please. And why is that? So if we think about it, and again, don't worry, I really just want you to focus on the bottom part of this slide. So just to look at our progesterone, which is done in a yellow, pale yellow, and our estrogen levels, which are done in pink. So during a typical menstrual cycle, we have our surge in progesterone, which happens around ovulation, and then that drops off very quickly. And then we have this surge in estrogen, which then tends to drop off before we have our periods. So there is possibly some reason, or there is possibly some explanation that this could be the case in relation to our menstrual cycles, that the role of estrogen in particular may be important. However, and I spoke to one of our consultant colleagues today. Again, this is an area that is poorly understood, and certainly you would hope going forward that there would be more studies that would sort of look at this in more detail. And I think as the whole area of women's health is coming on board, I think this probably we will, as time goes on, we will probably understand the role of hormones in relation to possible flares of our disease. Next slide, please. There was another study from 2019, which looked at pregnancy outcomes for women who have fibromyalgia. Now, I just maybe start a little bit on my experience of looking after women with fibromyalgia. And in the main, these women can get pregnant quite easily and can have normal pregnancies, and sort of have you know, a good postpartum period. And again, I'm sort of conscious that we have access to our reproductive health team. So these women can have access. We just go back a slide a little bit. We just hopped, sorry, Martina. So that these women have access to care. But just to have a look at a study from 2019. So this was a Canadian study. And what they did was they looked at the effect of fibromyalgia on maternal and neonatal outcome. So again, there's some limitations to this particular study. This was a population-based retrospective study. So they looked at a databases for a 14-year period from 1999 to 2013. So there were over 12.5 million births during that time. And of those 12.5 million births, there were just almost 8,000 women who had fibromyalgia. And that is representative of 0.6% of all the babies that were born during that time, which may explain why we're not so knowledgeable about fibromyalgia, because it is a tiny percentage of the general population. So when they looked at these women, these 7,000 births, and again, they had no histories. All they were doing was looking at databases. They found that these women were tended to be older in age, and we know that being older in age has a risk of making it more difficult for you to conceive and having more complications during pregnancy. These women tended to be overweight, user of alcohol, tobacco, and illicit drugs. Again, so this is 99. This is some time ago, sort of when maybe reproductive healthcare in general wasn't so well managed, and because of their weight, they tended to have a higher risk of gestational diabetes, which can have a negative outcome on a pregnancy. What was interesting is that there were no medications included in this analysis. So again, this was basically just looking at a database and sort of, making quick decisions about the pregnancies that they had. So again, really, I'm just emphasizing that there isn't a lot of information within the rheumatology literature in relation to fibromyalgia, but let's hope that that changes going forward. Next slide, please. So again, when it comes to prescribing, and we do have some good guidelines and support for us when we are prescribing medications during pregnancy. So this is from the British Society of Rheumatology prescribing guidelines for our patients who are pregnancy planning and during pregnancy in the postpartum period. So again, if I draw your attention, I suppose there just on the top box you have, in the green box, you have the drug, whether they're compatible around conception, compatible with the first trimester, second and third trimester, and compatible with breastfeeding. This is whether they're compatible with paternal exposure. So the medications in general appear to be compatible with around conception and during pregnancy and for breastfeeding. And that sort of holds for paracetamol, codeine, and tramadol, as well as amitriptyline. However, if you have a peep here at the gabapentin, which I know some of you might be on, back in 2016, the advice was there wasn't a whole lot of studies looking at gabapentin in pregnancy. However, we have new guidelines coming out later on this year from this same group. And basically what the new guideline is going to suggest is that gabapentin may be used, but at the lowest dose possible, so that this medication, because the benefits can outweigh the risks. So again, this is a discussion with your rheumatologist or whoever is looking, whether this is your GP or your obstetrician, that again, it's about looking at these medications and saying, well, okay, well, what is the lowest dose that we can use on them? I can't actually share that particular information with you because it's not published. But again, there are some changes in gabapentin and pregabalin going forward. But the rest sort of seem to be compatible around pregnancy. The non-steroidals, which you may use as pain management, again, can be used around planning pregnancy. However, if you're actively trying to conceive, or if you think there is any chance you are pregnant, the obstetrician's advice is that it should be avoided. Because we know that non-steroidal anti-inflammatories, especially the COX-2 inhibitors, so things like Arcoxia, that they can interfere with ovulation and possibly increase the risk of miscarriage. So again, when it comes to medications, and again, this is just a slide, a snapshot, which can only be used in consultation and having that chat about how you are and how you're feeling and what medications need to be prescribed. Next slide, please. So I love this slide, and it's a slide I use a lot because whether you don't have fibromyalgia, or you have any woman trying to conceive, there is a concept of care which is about planning for health and being fit for pregnancy. So preconceptual health, and this applies to everybody, whether you have any condition or you don't, that the health of women and men during their reproductive years in which they can have a child. So that's what preconceptual health is about. And good conceptual health encompasses two main concepts, which is planning from the pregnancy, and that's usually done in consultation and enabling women and their partners to choose if and when to start and grow their families. And then there's the bit about being fit for pregnancy, and this applies to us all, or anybody contemplating pregnancy. It's really about recognizing that many pre-pregnancy health behaviors and risk factors are amenable to change. So if we have the next slide, please. Now, again, this is non-specific, but again, we can adapt it sort of into any of our conditions that we manage in rheumatology. So thankfully, I have rarely come across anybody who is smoking, but we know that that smoking is to be discouraged, and should be people should be strongly advised to stop smoking if they're contemplating pregnancy, because we know it causes, and this is in the UK now, up to over 2,000 premature births, can be responsible for miscarriages and perinatal deaths. But it also increases the risk of complications in pregnancy and to the child developing in the womb. So these include premature birth, and none of us, we want our babies to be delivered at term. Low birth weight, problems of the ear, nose, and throat, respiratory conditions, obesity, and diabetes. So these are, things. These are our lifestyle changes that we can make, that we can adapt ourselves to improve our outcomes for pregnancy. Next slide, please. If we look at obesity, so obesity is a preconceptual risk factor. So we know on women, it can make, certainly women it can be more difficult to get pregnant in the first place if you are overweight. It also increases the risk of miscarriage. It increases the risk of gestational diabetes and perinatal complications. And we know that women that are overweight can have lower breastfeeding rates. But again, remember, it's not only the mother it affects, it can impact on the fetus. So we know that women who are overweight have an increased risk of stillbirth, increased risk of metabolic abnormalities and developmental abnormalities. And then for the children that are born to women who have who are overweight, there is an increased risk of obesity for the children and diabetes. So again, these are things that any woman contemplating pregnancy can change and adapt. And again, being a normal weight and exercising regularly is going to improve your chances of conceiving. Next slide, please. And just to mention on infertility, because whether, and this is UK literature, but certainly it doesn't differ a lot from our own HSE advice, but they suggest that 1 in 7 couples, these are couples out in the community who we don't know whether they're living with an inflammatory arthritis or any other comorbidity, can find it difficult to get pregnant in the first place. And that, we have some women who are attending the fertility services. and sort of there's lots of permutations for that. Sometimes there can be the issue, a fertility issue with their partner, or that they have, you know, they are in their early 40s and they want to conceive as quick as possible. So again, just to remember that, you know, just because, you know, that 1 in 7 couples who are planning pregnancy may have difficulty in achieving a pregnancy, and that certainly warrants further investigation if this hasn't, if pregnancy hasn't happened. Now, the general advice is that if you're under 35 and you have been actively trying to conceive for over a year, that's when you should see a fertility advice. If you're over 35, that time is reduced to 6 months. So that is having, you know, regular sex and a sort of that, you know, contemplated time of, you know, actually actively trying to conceive. Next slide, please. So these are just key areas to think about when planning your pregnancy. And I know many of you that are on this webinar are living with fibromyalgia, but it's really, really important to have the discussion about your family planning with your rheumatology team or your primary care team, whoever is looking after you. And if you go to your appointment, and I say this with a hand and a heart, if you go to your appointment and you really want to talk about pregnancy and nobody has asked you, you bring up the topic. You know, say, look, I really would like to talk maybe at the end of the appointment about planning for a family. And that just gives the clue and reminds those that are seeing you, okay, we need to talk about your condition, but we also might need to talk about medications. As with any of our women who are living with an inflammatory arthritis or with fibromyalgia, the best time to consider a pregnancy is when your symptoms, when you're well, when you're feeling well. Because if you think about it, if you are feeling unwell, it's going to be harder even to contemplate pregnancy. If you are, or sex, should I say, if you are, if you've lots of pain, well, then the act of sex might be difficult. So it's really the time to give yourself the best chance is to when you are feeling at your best. That's when you should consider pregnancy. Think about the changes that we can all make, whether we're living with fibromyalgia or not, to our lifestyle to improve the possible outcomes. So that means getting pregnant, having a healthy pregnancy, and a good postpartum time. And then there's the other things that, you know, every woman has to do, and that's to include folic acid in their medication regime for 12 weeks prior to the planned pregnancy. And that usually is continued right up until 12 weeks of pregnancy, so the first trimester. The other thing that our obstetrician colleagues like to have is that you have your cervical smear up to date. So those are things that you can sort of follow up with your GP and say, look, it's a year since I've had my cervical smear. I'm planning pregnancy, so I want to have my smear done. And also have vaccinations, any vaccinations that you're due, you know, to have them up to date, because they are important sort of for your pregnancy. One to look out for is rubella. And that's just from my own experience. We have come across a lot of women who have sort of remember having the rubella at you know, when they were 12 or 13 and go, oh yeah, no, I had it. But then when we check for it, maybe the vaccination is worn off, but they're not immune to rubella. Rubella can be detrimental to a developing fetus. And so again, it's nice to know that you are rubella immune before you contemplate pregnancy. So then if you come across rubella during your pregnancy, you can go, okay, I know that I'm fine because I know I'm rubella immune. So this is what this preconceptual phase is all about. Next slide, please. The menopause, and again, you know, we could do a whole session on menopause, but really, next slide, please. I just wanted to really just to highlight to you, and this is what, you know, when we're in the clinic and we have patients, and you know, I feel we're getting better at asking people about you know, where they are in their in their life cycle. So whether that's pregnancy planning or they're still having their periods, and usually that's how I would ask: are you still having your periods? And just people go, oh no, that they've stopped. So again, it's just about being able to identify, well, which are we know that some fibromyalgia symptoms can be similar to those who are experiencing menopause. So again, it can be a little bit of a challenge or a jigsaw to try and sort of, figure out which is which, but it certainly can be done. So I'm not going to go through this. Dorcas has highlighted these in great detail. But again, just to think about, that sleep pattern, and just to highlight the brain fog, things like that, which can be, if we go to the next slide, if we look at the symptoms of menopause, if we look at here, we have, mood swings, fatigue, dizziness, weight gain, anxiety, depression, breast pain, headaches, that itchy, crawly skin that sometimes our younger patients with fibromyalgia will describe, that can be a symptom of menopause as well. So again, and we do know that with menopause, we can have aching joints and muscle problems. So again, it's a little bit it requires a little bit of detective work to be sure, okay, well, is this fibromyalgia, or is this menopause, or is there something else going on? And sometimes that takes a little bit of time to figure that out. Next slide, please. And then just suggestions for self-management. And again, these conditions can be managed very effectively. So just to highlight, it can be a challenge for your clinical teams to ascertain which symptoms are which, and it can be a little bit of detective work. Discuss your symptoms with your rheumatology team. And please, if they don't ask, if that's all you take from this, if they don't ask, please ask them, share that, have that point in your, maybe on your phone, or maybe on a little piece of paper left beside you, and just say, I'm not leaving here until I've mentioned that, and see where, what, they might say, well, look, we need to look up into that, or we look at that the next time, or whatever. But please bring that to the attention of your rheumatology team. And remember, there's lots of information available online to manage these symptoms. It's really a case on how best to access it and to use reputable sites. And again, of course, as I was doing this, maybe this is something that we could do, maybe through Arthritis Ireland, have a look through, and I'm sort of popping this now onto my team, but we could look at maybe some websites that are reputable that could be maybe put up onto the Arthritis Ireland website. Because I think there's some really good information out there. We also have, and I'm sure a lot of you are aware of that, or those of you who are in the menopause or think that you may be menopausal, that there has been the new menopause hubs, which we have one in Holles Street, which people can self-refer to. So again, we're starting to talk, the conversation is coming about time, and we're starting to talk about menopause and what it's like to live with menopause. And believe you me, most of us are going to be living, probably 50 years with menopause, but so we have to sort of manage it and stay well and do the best we can. So that's really as far as I am in the time allowed, but I'm happy to answer any questions, and I'm sure Dorcas is as well.
Thank you so much, Louise. That was great. I'm seeing lots of hands and stuff there. That was fantastic. Thank you for that. And I think everybody would agree that that was just fabulous information from yourself, Dorcas, and yourself, Louise. So thank you both very much. Mm-hmm. I'm just checking out some questions that we have. Somebody's saying here, hi, I've recently been told that my symptoms point towards fibromyalgia, but all my pain, weakness, pins and needles is on the right side of my body. My left side is unaffected. Can this still be fibromyalgia, as I have read that symptoms should be widespread and include both sides of the body?
So I will take that question. Can you hear me okay?
Yeah,
I've seen some people couldn't hear me properly earlier. So, I mean, in the past, the way fibromyalgia was diagnosed was with 18 tender points that were palpated, and that helped to diagnose fibromyalgia. Now, the new guidelines now state that a person should have at least 4 out of the 5 regions of pain in over a 3-month period. So, for instance, the right upper, left upper, right lower, left lower, and also to include the neck and the back and shoulders and so on. So 4 out of those 5 regions is the guidelines. So, but also fibromyalgia pain can shift from one part of the body to the other. So that may need to be considered. And this is the main reason why they stopped the 18-point diagnosis kind of guideline, because it meant that depending on whatever day the person is examined, it may be a false, diagnosis. So, I mean, if the person who's asking is not sure, maybe a neurological examination can be done or further tests just to make sure, that there's a right diagnosis there. This is where the complexity of fibromyalgia comes in. I hope that answers a little bit of the question.
okay. Thank you, Dorcas. There's a question there too that somebody has up about antidepressant prescribing. That why is it that it's only antidepressants for fibromyalgia that she's been prescribed by her consultant, and that it's all she's ever been offered? I think you went through the list of types of medication, but this particular lady's only ever been offered antidepressants.
You see, sometimes it depends on a individual basis. So depending on what her other conditions are, or what her sensitivities are, or what else she's on in terms of medications at the moment, maybe other medications may not be suitable for her. For example, we have also, like I said, there anticonvulsants, maybe they are not suitable for her, or even opioids, they are mostly not suitable for most people and they're discouraged. So that could be the reason why they want to try the antidepressants first. And then hopefully, if those don't work, they can try to explore other options.
Okay, thanks, Dorcas. Somebody has on an observation and a comment here as well about, the lists of medications there, Louise, that you had up during breastfeeding and pregnancy. And there's a whole very extensive comment there to everybody, but there's a breastfeedingnetwork.org.uk. They've highlighted that as a possible website. And it's with information there on antidepressants, and there's guidelines there about stopping breastfeeding or stopping the antidepressants, which isn't always a good thing either. And somebody's also asked for some suggestions for information or websites with information on fibromyalgia and everything that you've been talking about, really, and anywhere that you can refer them to.
Oh, you mean for fibromyalgia? Sorry. I thought,
yeah.
Okay.
Yeah.
Well, I mean, there is an up-to-date website that is really good. It provides patient information. So it also gives clinicians information, but there's sections on all of it. It's I think, www.uptodate.com, if I'm not mistaken. And then Arthritis Ireland has good information about fibromyalgia. There's so many examples, but I think if they start with those two. Now, the European League of Arthritis also has information for patients, and I sometimes give patients a lay section of the fibromyalgia information, and it's very simple and straightforward. So if they go onto the EULA website, they will find information there too.
Thanks, Dorcas. There's a question here. Is a lady struggling with fibromyalgia for a long time, since late teens? Currently going through the menopause and has a complication of an underactive thyroid. So it's been really hard to sort of address the fibromyalgia. She's been in constant flare for a couple of years now. Very hard to keep going. She's really struggling with the brain fog, losing weight and getting fit is extremely difficult, especially with the underactive thyroid. And she's struggling with an active work life with small kids, and she's asking for any tips. And she's been asked to go for physio again, but find it hard to fit it all in. So just, I suppose, it's that boom and bust thing and trying to live in the middle.
Yeah, absolutely. Yeah. And I suppose, this is a sort of a challenge for it's to fit everything into this day. And that exercise piece, while it is very, very difficult to fit in, it's, if you can persist with it, it's going to give the energy and make life a whole lot easier going forward. But I appreciate it. I've had young kids and I know sort of the craziness of how to fit things in, but to persist and to try and sort of even have that short time of input, into herself and about her exercise, which, and I, hands up, I know exactly, it's tricky, but we all sort of need to, I suppose, try and challenge ourselves to keep ourselves well. I see a question, coming up about the cervical smearing. So just, I suppose, just to highlight that, I probably went over it a little bit quick. So our obstetrician colleagues like to know that your cervical smear is up to date. So whether that was done, and it's amazing. And I had a lady today who sort of has said, oh yeah, I keep ignoring it. So, again, it's a conversation that we have with women to just encourage them to have their cervical smear or to have their screening done. So and especially in case there is any complications during pregnancy, because that's not the time to be dealing with any issues or any surgeries that need to be done. Okay.
Thank you, Louise. We're running out of time here. People, I'm really sorry. I don't think I'm going to get to all these questions. We're asking, somebody said that they were being seen by a consultant, but they haven't been seen for years. And should they be under the care of a consultant or under the care of a GP? And I think that's going to have to be our last question, unfortunately. Okay. Anybody want to go with that one?
And is this with fibromyalgia?
Fibromyalgia,
oh,
yeah.
Okay. So, I mean, I have come across patients whose GPs are so good at managing fibromyalgia, really, and I've been really impressed. So they continue to be managed by their GP. However, there are some GPs who they know themselves that they don't have enough knowledge, or they're struggling to help you manage symptoms. Then in that case, it would be wise to just go to a consultant for more help and, suggestions for therapy.
Okay.
Yeah.
Thank you, Dorcas. You were going to say, Louise?
No, I suppose, again, that focus on the Arthritis Ireland self-management program, sort of to use all those tools that are sort of around us to make things that much easier would be helpful as well. Rheumatologists in general tend to diagnose it and then see the patient for a period of time, and then they're discharged back to their GP in the main for patients who are living with primary fibromyalgia. For those patients maybe who have rheumatoid arthritis with secondary fibromyalgia, they tend to keep coming back to the rheumatologist mainly for the management of their other rheumatic conditions, if that makes sense. So there seems to be two treatment paths or care pathways for patients with fibromyalgia.
Okay, thank you, Louise. I know we haven't got around everybody's questions. I'm really sorry about that, but for now, I'm going to go on to Caroline's presentation. And if we have time at the end, we can do more questions, if that's okay with you, Louise and Dorcas, because I know there's a lot of interest there and there's a lot of questions coming in. So that might be the best plan of action, I think. So we're going to have a very big change of pace. We're going to talk or listen to Caroline Martin, who is a trauma-informed psychologist, and amazing work that's influenced by the work of Peter Levine and the mind-body connection. And, you know, looking at the mind and how we're influenced and how we experience pain and how we live with pain and how we work on a psychosocial model as well, which is really interesting. It's a lovely change of pace, and hopefully you'll find it of interest. And, you know, we can learn from it as well. So for now, I'm going to hand you over to Caroline. And Caroline, if you're okay to share, you share away. And if not, let me know and I can share. Okay.
Thanks so much, Martina. Yeah. Fingers crossed. Okay. How does that look? Is that okay? Can you see the title slide there? Great. Okay, super. Thank you so much. Okay. Just do a little housekeeping here for myself. Great. Okay, so first of all, I suppose I just really want to thank Martina for inviting me to be part of this event today. Kind of slightly daunted coming in after Dorcas and Louise, because I am not an expert by any stretch of the imagination on fibromyalgia. So actually being invited today is a little bit daunting for me. I will state that and put that disclaimer out there from the get-go. I suppose I was really keen, however, to turn up tonight and to be part of this, because it does deeply resonate with me as a woman who has a lot of lived experience with, I suppose, being in and out of the medical model in that kind of field, with several pregnancies, not all of them successful, and in more recent years with breast cancer and a medically induced menopause. So it's very interesting for me, the whole concept or the whole area of female health and how it is dealt with within kind of what I would consider a largely patriarchal kind of system. So I was delighted to be invited today to talk on this topic and bring my experience and bring my expertise to bear for, and I hope it resonates with many of you. I would like to just reiterate Martina's advice at the beginning of this session to mind your own well-being, to stand, stretch, be comfortable. As she said, you know, there's no cameras on you, we can't see you, so please be comfortable, have your cup of tea, your biscuits, whatever it is, okay? And the other thing I suppose I'd notice is that having been kind of just on the background of this evening's conversation, there is a very lively chat going on, and I really value that. And I think I would ask you to lean into that space. And if you have ideas to share with one another, please use that space to do that. This is one of these events where it's so important for us to not only come with questions, but also come with our own experience. And if you have a question, and if maybe somebody else on the event tonight, one of the other participants here can answer that question, please do. Don't expect, or don't think that just because you're not on the panel this evening that you don't have answers. You all have loads of experience and loads of ideas and suggestions for one another. So please do lean into that space together. Okay. So as you see, my name is Caroline Martin. I'm a chartered consultant psychologist. My email address is there as well. And up until quite recently, I worked in the public service and then went out on my own in November of last year. So I've got over around 20 years or more than that now of experience working in psychology in Ireland. And so I did my training in the US. So, okay. So just briefly, what I'm going to go through today is I'm going to just turn the emphasis slightly away from the medical model to that biopsychosocial lens, which I think actually really fits with fibromyalgia. And then I'm going to introduce a kind of a way of understanding our stress response system. This is called the neurosequential understanding of our stress response system. And I'm going to talk a little bit about how our brains work, being really mindful that I'm not a medic. So it's going to be a very kind of rudimentary way of looking at it. So, and then looking at our stress response system and looking at a proposed theory, which is the polyvagal theory. And then I'm going to bring all of that together with some research on how actually we can respond to feeling overwhelmed, feeling in crisis. Okay, and then those last few bullet points there are kind of, they're the nice to if I get to kind of end of the presentation today. So I because I'm not an expert on fibromyalgia, I kind of just quickly went in. I'm always very interested in these kind of word bubble things that they can create now, and I just put in fibromyalgia word clouds, that's what they're called, sorry, and to see what came up. And it was astonishing for me how similar all the various word clouds were in terms of the terms that cropped up for people when prompted to think about fibromyalgia. And I was very much taken by how the words that come to people's minds are very much influenced by the medical model that we have. But as Dorcas intimated, or she actually said earlier on, and with one of her slides, which I thought was really interesting, fibromyalgia is very systemic. It takes over not only your entire body, but also how you may perceive yourself, how you interact with the world, all of those kinds of things. So that really struck me as I was kind of reading a bit about it. So you have the symptoms, then you kind of go and you get a diagnosis, and then there's treatment. So this is a very kind of medical model kind of way of looking at it, and then there is the management of it. So I was trying to, I suppose, conceptualize it in a framework that I was familiar with. And for me, the one phrase that kept coming up is the work I've done in the past on critical incidences. And a critical incidence as a comparison kind of fits, and forgive me if it doesn't fit for you, okay? But the reason I suppose I consider it like a critical incident is that the definition of a critical incident is that there's an event or a series of events that overwhelms the normal coping mechanisms of the system. So again, it's a systemic piece. And this is an accepted definition, much like there would be an accepted definition of fibromyalgia. But in reality, when the day-to-day living of these things, it's actually very, very nuanced and can be really impacted by people's personal life experiences. So while we may have a nice definition, and there's a chapter in a medical book on fibromyalgia, actually the reality of it for people living with fibromyalgia is actually very nuanced. And so that is why I suppose I really appreciate the event like this evening, where people can come together to consider that diagnosis through the lens of many experiences. So the expertise and experience that Dorcas has and that of Louise is really quite different, and so complementary. And I think that offers us an opportunity to consider not only our own perspective, our own experience, but our own potential experience and our own potential expectations and impact of a diagnosis for us. So I think that it just kind of broadens things out a little bit for us. So that then led me on then to, I suppose, looking at fibromyalgia through this biopsychosocial lens, which, essentially takes in account the physical aspect of it, the psychological aspect, and then that social piece where we interact with the world. Okay. So one of the things that I found really interesting when I was reading up in preparation for this evening is that there are a number of people that link the initial onset of fibromyalgia symptoms to an actual physical or an emotional trauma, and whether that is it could be a severe illness or an event, it's kind of a traumatic life event that kind of really kind of disrupted their usual course of events for their lives. Okay, so if we think about it in terms of that area of trauma, I really quite like the work of Bruce Perry. He's a psychiatrist, and he's recently done a book with Oprah Winfrey, and so he's kind of really become kind of mainstream now at this point. And he kind of describes trauma, or he suggests as well that trauma should be understood in the concept of these 3 E's, that there is the event, but then there's also the experience of that event, and then there's the effect of that event. So this really emphasizes or recognizes the individuality of our experience. So there's an experience that's impacted by biology, so simply how old we are when we experience something, the gender. We know that women will experience things differently to men simply because of the the culture that we're that we're living in, and substances. Okay, then there's also the psychology end of things. So our skills, the skills that we have developed in the course of our life, that will help us overcome or take on challenges, or indeed not. Okay, and then our emotional valence, that ability to kind of move up and down a range of emotions without getting stuck in any particular place. This is kind of that psychological skill set that we bring to bear on our experiences of an event, which may or may not be traumatic, depending on all of these things. So it's about our thinking. So it's interesting to hear what they're saying. I think it was Dorcas said about the CBT has a good evidence base for people with fibromyalgia, because that really looks at our thinking patterns, it challenges our thinking patterns, and within that then we can create these new beliefs about our capacity, and new beliefs of perhaps our value and our self-worth, etc. So these are all the things that kind of bring to bear on how we experience a particular event. The other thing, I suppose, here is that social supports. So our relationships, how do we experience those relationships? Are they places of solace and nurture, or are they actually places of threat and danger? And that will have a big impact on how we experience any particular event and our access to certain networks. So some parts of our society are much more readily able to access networks of support. But actually there are other groups within our society, ethnic groups, who perhaps are not able to access those networks simply because of discrimination, or not being aware of how to access those networks. So all of these things really come into play about how we actually experience certain events and whether they become traumatic or not traumatic. So essentially our experience of events is not uniform. In fact, our experiences of the same event can be wildly different. And that may be because of gender, race, ability, previous life experience, and access to supports, among other contributing factors. And indeed, the presence of supports and ease of access to those supports will influence the effect of that event on each of us. And so in essence, there are these three components to determining whether an event is traumatic or not: the event, or indeed the series of events, which could include systemic injustice. So, if somebody goes into the hospital and they're left waiting there for, half a day or something to be seen by somebody, that's one event. But if somebody actually has been bashing up against the medical system and not been able to get to see a consultant or a specialist time and time again, and perhaps have brought their children with various difficulties and injuries, whatever, and have been left there, that kind of systemic injustice due to your ethnic group or your background, that can also play into how you experience the event. And then there's the individual's experience. That plays into the individual's experience of the event. And finally, the effect on the person. Okay, so the actual impact on the person. So that's, I suppose, I like to use Bruce Perry's 3 E's to understand trauma, because it really emphasizes how two people can be in exactly the same situation, experience the same event, but rather they will be present at the same event, but they will experience it differently, and the effect on them will be differently. Okay. So then I suppose I'd like to introduce this Peter Levine. He's a psychologist, and I really like his whole idea of what we can do when somebody experiences trauma. And he really kind of takes on that idea of the effect of trauma, and he says actually that really it is about what we hold inside us. The effect of trauma is what we hold inside us in the absence of an empathetic witness. So this is really about, if something happens to us and we experience it a particular way and it has an effect on us, if that is actually acknowledged by somebody, genuinely acknowledged by somebody, and your experience is validated and seen and not judged and is accepted, then actually the healing in that moment is really quite significant, and it changes the effect. It disrupts that effect basically for that person, and a different experience can then be had, because they kind of now relate that this event happened, I had this experience, it had this effect, and that effect was acknowledged by this person. I felt held by this person. I felt validated by this person. And now I can kind of grow out of this whole experience. Okay. The trouble happens when that doesn't happen, when we are not validated, when we are not seen, or when we are dismissed. Okay, that's really when the trauma kind of takes hold within our systems. There's a definition of empathy, which is from Mohsin Hamid. He's a novelist, and that I particularly like, because people often confuse the concept of empathy with sympathy. Sympathy is kind of like feeling sorry for somebody, but empathy, as described by Mohsin Hamid, is about finding echoes of another person in yourself. So it's like allowing yourself to drop into that well of pain so that you're able to sit with that other person who's experiencing pain, and it's being able to sit with them in that space. And so it's about finding echoes of another person in yourself, which I think is a beautiful way to describe empathy. Carl Rogers, he's a very famous kind of psychotherapist. He talks about this kind of how change can happen. So as I said, when you have this empathetic witness, that you feel not only validated, but you also feel accepted by this other person without judgment. And what happens is that when somebody else begins to accept us, it helps us accept ourselves. And then, as he says, the curious paradox is that when I accept myself just as I am, then I can change. So I really like this. It's so empowering that when somebody sits with us, when we have that empathetic witness, when we feel accepted, then I accept my experience of the event. I don't continue to judge it. I don't criticize myself or anything like that. And I accept that actually I am valid, I am valuable. And now I can actually start to perceive and conceive of another way of assigning meaning to this event, and that is perhaps going to allow me to change. Okay. So I would invite you to just consider your own experience of fibromyalgia. Perhaps you've been fearful of it getting worse, perhaps in the process of the entire experience, we've lost friends, a position in the world, a position in the family, perhaps anxious about how others see you, and all of that is valid, and it's your own, and it's individual to you, and others will come with their own fears and concerns, which are equally valid, and they're informed by their own life experience. So, you know, the range of internal thoughts and experiences and feelings is fully valid. That's the really key thing here, that because what can be quite damaging is kind of a cycle of judging yourself for those thoughts and kind of feeling that's shameful or whatever, that's not helpful, that these are all really valid, to have all of these experiences and all of these feelings in response to these events. And they are informed by our life experience and the presence or not of an empathetic witness during moments of distress. So some of us will have heightened stress response and will be alert to any potential sharks in the water, regardless of whether those threats are real or not. That's the thing, is that, when we have a heightened stress response, we are just constantly in that state of alertness for sharks, any threats at all, regardless of whether it is they're there or not. It's a position that we take on. So it's that idea that we may all be in the same storm, but the boats we're in are all different. So while yes, there might be a range of people here tonight with fibromyalgia, there's going to be a range of different experiences, and that is going to be informed by our life experience and people and our accessibility to a support network. So within that, then there's, some of us who are kind of on like your super yachts, and others who are on quite dodgy looking rafts. So sharks look very different from those two vantage points. Okay, so if you're in a super yacht, those threats might look curious and interesting, and something that you kind of go and you research and you learn about. Whereas if you're on a dodgy looking raft, you may feel more kind of, I just need to just protect and batten down the hatches, and that's really understandable. So how, I suppose what we have noticed through the research is that there are essentially 4 ways in which an event may become traumatic for a person. And one of those is the sheer size of it. So the demand that it places on you physically or psychologically, that in and of itself can actually make it traumatic. Another one then is devastation of resources. So we are so aware at the moment that and it's not just now, it's actually quite long standing now for a number of years since I've become kind of, I suppose, acutely aware of it on a personal level, this difficulty to access medication. We're aware of this, and even some of the people tonight talking about, well, I have access to this, but nobody's considered offering me this. And, what is this about? And we know that there's difficulty at the moment accessing HRT medication. And in the past, I know we would have had difficulty accessing some medication specifically for breast cancer. So this can become quite traumatic for us. And then a loss of safety is a third way that we can experience event as traumatic. And this is where our own kind of secure base, our bodies, become infiltrated with a threat, that really rumbles our sense of safety. And then finally, then the fourth way that we can experience or consider something as traumatic is if it has an impact on our sense of meaning or our social justice. So again, I suppose I'm so mindful that, for many people, the access to healthcare, that there's a great disparity there about provision and care, the rates of fibromyalgia amongst the female population versus the male population. And we also know that within the female population, that there's more women that are at risk of comorbidity as well with other difficulties and disabilities. So how we sense, experience, and make sense of events that happen to us is in large part down to how our brains are wired. Now that's partly through to evolution and also through early life experience. So let's have a little look at that one. So this is, so how we make meaning of those experiences and those feelings is important to us to help us understand, as it gives us an insight into how and why we respond in the myriad of ways that we do. So while some of this is down to evolution, as I said, some of it is also down to early life experiences, but what we're becoming more and more aware of is actually neuroplasticity, our ability to rewire connections in our brain through new awareness and new experiences, okay? So I particularly like this very simple hand model of the brain, which is proposed by psychiatrist Dr. Dan Siegel. And he talks about it as the hand model of the head brain, as he just makes it distinct from the gut brain or the heart brain, and to explain this neurosequential way that we process information. So by knowing how the parts of the brain operate, we can begin to think about how or where to direct our attention. So to activate certain areas and to get them to work together. So the first part then is this lower part, it's obviously not in your hand, okay? But he's just using a model of the hand, which you can actually do by yourself. So the idea is that if we make a brain like this part right here, the wrist part here would be the kind of where the brain stem is, okay? And the brain stem, which would be right here, and then the limbic system, which is right here, or there we go. That's part of it. He's going to use your thumb tucked in. It's kind of like the limbic system. And then finally, you've got your cortex and your prefrontal cortex. Okay, in this right there. Okay. So what Dan Siegel would propose is that all these parts work beautifully together, okay? The brainstem and the limbic system, they work together to regulate your arousal, your emotions, and they activate your stress response system. And it takes information from our bodies, such as our breathing rate, whether we are hungry or thirsty, whether we have an itch, okay? And it brings all these together. So there's 200 million year old limbic system, okay, when we became mammals, works with this 300 million year old reptilian brain in the brain stem, okay, that's what they call the reptilian brain, and creating emotions and motivation. And it appraises the meaning of things, right or wrong, in a situation, whether the situation is right or wrong. And then memory is also connected through the limbic system to the hippocampus and the attachment process in childhood and through our life for protection and soothing. Okay, so these, if you think about how our brains develop, even when we are inside the uterus, it begins with this very, very basic, and the brainstem, then your limbic system, then the cortex and the prefrontal cortex. Then this is the last part that develops when you're in your adolescence, which I think really stretches well into your 20s now. So certainly now, when I have a 17-year-old at home, I'd like to think he's not quite there yet. Your memory is connected through the limbic system to the hippocampus and the attachment process in our childhood and throughout our life for protection and soothing. And they sit below the cortex, which is like what he describes as the upstairs brain, which allows us to perceive the outside world, think and reason. And that's the area that helps make maps and connections between different things with sight and sound. So if I see this, it means this. It's like when you hear a siren, you can just hear a siren and you know that actually there is an ambulance or a fire brigade or whatever on its way. You don't even need to necessarily see that, okay? And then the frontal cortex is the association of thought. Prefrontal cortex is the part that regulates the subcortical, the downstairs brain, and the limbic areas of the brain. And it's involved with integrating all of those different parts. And mindfulness really helps us integrate all the different parts of our head brain. And the more integrated we are, the better our well-being, the more healthy our relationships tend to be with our others and with nature, with creativity. We tend to be much better able to collaborate when everything is beautifully integrated. However, when we're tired or when we're triggered, we can, what he would call, flip the lid. Okay, so that basically derails the cortex, the prefrontal cortex, and brings us back to our kind of very basic rudimentary systems, okay, the downstairs brain. So being aware of this, that when we're tired or triggered, that we can flip the lid, being aware of that gives us the opportunity to become aware of what leads up, what are the signs that lead up to flipping the lid. So I love this quote. So although many of us may think of ourselves as thinking creatures that feel, biologically, we're actually feeling creatures that think. Okay, I think that's let's get us all down to brass tacks here. So we are first and foremost animals. We sense and we feel before we reason. And this is very important because for so long we've responded to stress and anxiety with reasoning, saying things like, calm down, what's wrong with you? And then we're surprised when the person doesn't immediately feel heard or feel automatically better, when no one in the history of calm down has actually calmed down when instructed to do so. So why is that? Well, as animals, we are built for survival first and foremost. So if we perceive a threat, we react. The more threats we experience in our life, the more honed our skill is to access those reactions. So this is great if you're being chased by bears or snakes or sharks. It's also great if you're living in a war zone or in a neighborhood with a lot of crime. This is brilliant because we certainly wouldn't want to be weighing up the pros and cons of running if a bear is coming for us. But it's more problematic when we're trying to juggle parenting or workplace demands in the threat of pain or fatigue, etc. So there's that there. Okay. So our stress response system. So different life experiences will determine whether we experience something as positive or tolerable or toxic. So for some people, we find roller coasters, for example, really exhilarating. And so that would be like that positive stress, while others will get on a roller coaster simply because they want to connect with their friends and they know it will be over soon and they'll have the chance to say that they did it. So that's kind of your tolerable stress, whereas others will really genuinely struggle to get on the roller coaster and they will fear genuinely that their life is in danger and they will not survive it. So fibromyalgia will also be experienced differently by different people. And yet I'm sure there's considerable overlap and shared understanding. So we've been living under an incredibly stressful context for the last 2 years now, and Dorcas noted that in this concurrent stress in her presentation. And our stress response system has not had an opportunity to fully reset, so for some time. And it's been operating our stress response system rather has been operating in the background, ready to be activated at a short notice. And this speaks to our unique life experiences that I mentioned earlier. And often people talk about being about people being dramatic or blowing something out of proportion. They may say people need to cop on or get a grip, but these terms really convey a lack of compassion for people's life experiences, and it lacks understanding. People's response to toxic stress is really simply a function of their automatic survival mechanism, which looks a lot like this. So when a person who has experienced trauma and has neither the previous successful life experiences of overcoming adversity, nor the presence of that empathetic witness, that individual will possibly feel unsafe and activate their stress response system without support, and they may find themselves stuck in this space. So you'll notice there that there's 4. Now, I think most of us are quite familiar with the kind of the fight and flight, these 2 up here. We often hear these being discussed, but actually there are these 2 here at the bottom, the freeze and fawn. And it's my experience that many more women present with freeze and fawn stress responses than maybe the other 2, which are more dominant in the national narrative, the global narrative. And the fawn response is very socially endorsed. It often goes unrecognized, and the connection between this response repeated time and time again and the physiological consequences can go unnoticed. And I think this really speaks to our early childhood as girls, being kind of told, oh, you're a very good girl, like you're a good girl, if you're a good girl, go get this for mommy, oh, that's very good, that type of thing. And you begin to feel, actually, I'm only loved if I'm being a very good girl. And then when things kind of go a bit awry, then you begin to kind of doubt actually whether we are lovable. So all of these kind of behaviors, and actually we'd see this as well with kind of that idea of kind of codependency as well. So let's go back to the need for our bodies to react quickly to threats such as bear or the sharks. And the problem arises when we get stuck in our stress response system, and it gets activated when there isn't a bear, but when there's an argument with our friends, or the threat of loss of friendship is there and all the support that that brings, or when there is a medical appointment or a performance review in work and the threat is that you're not progressing or in keeping with your hopes or in line with loved ones' hopes or family expectations. The problem is that our animal system doesn't distinguish between the bear and the fight with friends. It doesn't distinguish between the shark and the uncertainty of our body's capacity, or the risk of a fight with a loved one or a poor performance review. It simply just kicks into our threat response. So if we've had to call on our stress response for too often for prolonged periods of time, our systems can deploy them rather indiscriminately. And it's like we leave them running in the background, much like leaving tabs on in your computer or leaving apps open in your phone, and it drains the batteries. So we might do this because we feel, rightly or wrongly, that we may need to access them quickly. But much like those tabs and apps, they are draining our systems, and our system releases cortisol when our stress response system is active, increasing blood pressure, increasing blood sugar. That's great if you're in danger and you need to run from a bear, but it's not great over a prolonged period of time. So this constant activation of our stress response system is compromising our immune system, and it's compromising our body's way of warding off other ailments. So for this reason, we may experience recurring sickness and pain. This is the polyvagal theory. It's actually an unproven theory as yet, okay, because I think the world of the medical field is constantly evolving, constantly taking shape. But I did want to, I suppose, just flag it here. It is growing in terms of a concept in the whole world of trauma, and it pertains to your vagus nerve, which is the main nerves of your parasympathetic nervous system, which involve your involuntary functions, those managing your immune system, like I was just talking about there, and your digestion. And the parasympathetic nervous system is also the system that restores your body to calm. So, whoops, sorry, pushing on ahead. There we go. So when our stress response system is activated, even in that low energy mode, like I was talking about, when you have it's kind of running in the background, we are holding tension in our body. Some of us will hold it in our stomach, others will hold it in our joints, in our shoulders, in our neck, in our head. And pain in our muscles, bones, and organs, wherever we hold tension over a long time or too frequently, will in and of itself become quite distressing. Okay. So this is essentially just kind of a more kind of complicated way of doing the hand-brain model. So it's really about, how do we make sure that this brain stem, this very basic animal part of us, is feeling safe. Then how do we feel this limbic system? How are we going to connect? And then finally, how are we going to assign meaning to the experience? Okay, so there's the safety, connection, and then reasoning. So those are the three. That's the sequence in which we need to respond to our bodies. Okay. So I wanted to share this, and I particularly like this image. I think it's very helpful to understand that people may have a stress source that may be invisible, involving potential stresses such as family, recollections of shame, sensory memories that may not be understood, certain noises, smells, colors, textures. All of these things can actually be kind of triggers for memories. And they may also be impacted to a different degree with world events, or they'll experience oppression by virtue of stigma related to ethnic background or color of their skin. Those disabilities, visible and not visible. And we know from research that the majority of people have experienced some adversity in their lives, okay, which I think is really important. That most people, I think something like 60% of people, by the time we're around our age, will have experienced some adversity in our lives. And so our success rate here this evening is outstanding. It's absolutely outstanding. Our success rate of overcoming adversity is 100%. And I think we'd all take 100% in an exam any day. But how have we done that? How have we all managed to keep going and in so many respects thrived despite so much adversity? Have we all deployed the same strategies? That's really not likely. And I suspect some of the strategies we've employed ourselves, we may not even be fully aware of them. So I suppose I just wanted to say, when we think of the strategies that are really useful, Hopful's, this is a massive study that was done in 2009, or at least it was published in 2009. They identified 5 essential elements for effective intervention for these really traumatic, really adverse situations and experience. And the first one then is the sense of safety that is needed. Next one is calm. The next one is a sense of self and collective efficacy. Now that speaks to your belief in your own ability to survive or to thrive, okay, or to succeed in achieving a goal. That's your self-efficacy. Collective efficacy is when you believe in everybody else's ability plus your own, that together we will succeed. So we would have seen that at the beginning of COVID. If you remember back in March 2020, when there was the clap for the healthcare workers, and this was real sense of, I'm going to do my bit, you're going to do my bit. Those two actions are not the same, but they are really both of them are of huge importance, and we can all do it. So there was a huge sense of collective efficacy in the country. And then the next one then is connectedness. And the last one is hope. So you'll see how that connects or aligns beautifully. This piece of research aligns beautifully with the sense of our brains. So we need to have that sense of calm first and foremost. Okay, that's to calm that reptilian brain that we don't need. We're not running from a bear. Then that middle part there, that, let's be calm and connect with loved ones, with people that we care with, connect with ourselves, connect with the knowledge base, and then bringing in then that cortex, the part that helps us make meaning and sense of everything. Just briefly before I finish, because I'm very mindful of the time, I just want to talk about hope specifically. So instilling hope is critical, as trauma such as a diagnosis of fibromyalgia or cancer or whatever is often associated with a shattered worldview, okay? And catastrophizing can lead to despair and futility and hopelessness, because trauma in itself actually shows us how ill-equipped we are for such experiences. So hope, unfortunately, can be the first victim of trauma. Hope has been defined as a positive action-oriented expectation that a positive future goal or outcome is possible. I'm going to restate that. So hope has been defined as a positive action-oriented expectation that a positive future goal or outcome is possible. However, I think that perspective is very white, very Western, okay? While other people, I suppose this is what I would be saying, is that we have to understand hope as a much broader concept here, that for a lot of people, hope has a religious or a spiritual connotation, So how people access hope or build hope might therefore vary. Okay, so when we go to somebody and say, oh, look, you know, just get stuck in with a hobby, perhaps, you know, or get into work or that may not resonate. But so for those people, they may need to deeply connect with their faith. They may need to really lean on their faith, the sense that there is actually a higher power. And others will find that spirituality in nature. Okay, so I think it is important that we realize actually there's a variety of ways of us experiencing difficulty and adversity, but there's also a variety of ways of us actually responding in very, very helpful, productive ways for ourselves. Okay, so it's important that we normalize the range of people's emotions so they don't self-diagnose, that they don't self-diagnose responses that are perfectly reasonable within the context. And benefit finding is important because finding benefit can increase hope. It can take time to consider the advances, I suggest you take time to consider the advances of science and medicine. It's lovely to hear Louise saying about, you know, more research that's coming out with more information about different medications. And look for opportunities to experience altruism, that idea of helping others with no expectation of reward. So that's, if I could bring back to where I started from today, is share in the chat, share your ideas with one another, because actually giving away your little nuggets of wisdom is so empowering for other people, but it is a beautiful gift for you to be able to offer as well. So it's lovely to be able to do that. Now, I was going to go through a whole list of other strategies, but to be honest, I'm very mindful of the time. So I think what I'll do, Martina, is leave it there. Or do you want me to very quickly go through those? I'm not sure.
No, I think you're right. I think we're going over the time.
Yeah.
And you've covered so much. Oh my God. So it's fantastic. So thank you. And I think leave us wanting more rather than, you know, overwhelming, because and as you can see the reaction. So I would definitely chime in on that too. It's so interesting. My God, you know, the flight and fight and fawn and freeze. And the body keeping the score, and somebody mentioned somebody in the chat there is talking about the body keep the score, you know, the book.
That's
so
it,
we're all on the same page, which is just wonderful to see. So I would invite people to ask away questions. I know Peter's been typing frantically there all evening, answering questions for people as well. So if it's okay, I'm going to go back to the full panel because there's still some questions going. Let me see. There's right, okay. Could you say why some people with fibromyalgia are almost blanked by doctors, consultants, as they cannot see inflammatory markers, even though the symptoms are bad, and that's somebody's actual experience?
Well, I have actually heard so many patients saying the same thing. And really, I think it's just because of the complexity of fibromyalgia. All those other conditions are really straightforward, and consultants are used to saying, oh, okay, this condition needs this medication and that condition, you know, straightforward things. And this is why fibromyalgia needs a multidisciplinary team approach as opposed to a consultant. And as Louise rightly said on the last previous question, that, you know, primary healthcare team is the most suitable place for managing fibromyalgia as opposed to a consultant, really.
Okay, thank you, Dorcas. I've been living with fibromyalgia for 25 years. Symptoms are worse with menopause. Is there any real efforts to keep treatment other than prescribing medications? Some with serious side effects to support fibromyalgia patients, appropriate exercise clinic, CBT access. Where can I access the services Dorcas has referred to? I had to give up work in 2012 and I am getting progressively worse. And I think that's probably a question again for you, Dorcas, as well.
Okay. I mean, depending on where you live, I would suggest that people do research to see where they can find their nearest primary healthcare team, or even get referral by the GP to the nearest primary healthcare team, and they could guide them on what's the best way to manage and also, excuse me, where to get their cognitive behavior therapy sessions. And I know, Martina, you were also saying that with Arthritis Ireland as well, that you offer that. Did I hear you the last time? So there's another option for someone who wants to join your sessions and your courses in Arthritis Ireland.
Can I just add, just that lady, and I think it's all the same question, you know, her issues in relation to menopause.
Mm-hmm.
And I'm not really sure whether she has seen anybody or met maybe with her GP about menopause and about, you know, management of menopause. You know, certainly in the last 5 years, there has been an explosion or a huge interest within primary care in the management of menopause. So again, and they are so knowledgeable, and it's only, you know, I'll hold my hand up and say, you know, I'm one of those that you know, I went to talk to my own GP about menopause, and they were so knowledgeable. And of a super help. And this is a, you know, a GP down the country. So I think there's a lot of stuff out there. A lot of things have changed, certainly in the last, you know, 5-10 years. So I think it's, you know, I certainly would advise that lady, maybe first step, maybe to go back and just talk to the GP about some of those symptoms. It might be worth it, because there are benefits to some of the medications or HRTs, you know, for your cardiac health, for your bone health, that it might be worth trying something like that to, and there might be the absolute benefit that it might help with some of the fibromyalgia symptoms. You know, because do you remember I said that the fibromyalgia symptoms and the menopausal symptoms can be sort of mixed up, and it can be very hard to unpick which is which. So again, it's a careful discussion, and with your GP initially. For those that are living in Dublin, the menopause hubs, we've had some fabulous presentations from those teams. And again, the beauty of them is you can self-refer. You don't need any. You can just ring them up and make the appointment and have that discussion with those who are experts in fibromyalgia. They're not experts in fibromyalgia, but they're experts in menopause. So again, you know, there is lots of things happening and that are available for people to access.
Thank you, Louise. Somebody here has a comment that I read an article recently that connects fibromyalgia with the autoimmune system. Do you have any comments on that? And they're thinking that it was a King's College in London that did the research.
That's a very interesting question, because I also came across a paper that spoke about fibromyalgia and the immune abnormalities, I think it was, and that what it said was there is limited evidence to support the concept that fibromyalgia is an immune mediated disorder. But I think there was ongoing research regarding that, but that they found that the role of inflammatory markers in fibromyalgia is still unclear. Yeah, that is what I remember. That was a comment that
somebody had earlier was, does fibromyalgia fall under the classification of rheumatology, or is it neurology, or is it endocrinology? You know, because it has a footnote sort of.
Yes, definitely rheumatology. Yeah.
Yeah. Okay. Let me see, what else have we got? Sorry, everybody's thanking us here. Yeah, somebody's saying there that if you don't get the right answers the first time, don't give up. Keep accessing the resources until you get.
Absolutely, I would absolutely agree with that. You know, and that's what we do as for those of us that are seeking help. You know, about different conditions or different things that are going on, are like, you know, persist, you know, until you have a better understanding, until I certainly would agree with that. Persist. Yes.
Yeah. And Rachel is on here Rachel Lynch is on here from the Fibromyalgia Support Ireland. Hi, Rachel. And it's just there on the chat if anybody wants to see it. It's the research, the new study that shows fibromyalgia likely the result of an autoimmune problem. Okay, so thank you for that, Rachel, as well. Okay, so if it's okay with everybody else, I'm going to close the questions for now. But what I am going to do is I'm going to put a nice book on what we can offer at Arthritis Ireland, because I think it's really important that we, that we have a next step, because we've got a lot of people here that are really interested in learning more and doing something, and there's obviously a real appetite to do something and to talk all things fibromyalgia. So from an Arthritis Ireland perspective, it's the next steps piece that, that I really want to step in on steps. And I suppose the first thing that I want to let everybody know about is our wonderful national helpline service, which is run on Monday to Friday from 10 a.m. to 4 p.m. It's peer-led, led by volunteers. So, anything that you will not be able to answer everything, but, a bit of support, a listening ear, signposting, information, direction, it's all there, and it can be a great starting point that if you are struggling to find out something, or you need clarification on something, or a bit of reassurance, or how do I find out about this, or what did you do, or where do we go for that? It's a really, really wonderful service. And as I say, it's Monday to Friday. And we also have a Facebook forum with over 3,000 members, and that's a closed group, but it's great support for people as well with all sorts of rheumatological conditions, including fibromyalgia, and combinations of diagnoses as well. So just to let you know about our courses too, we have a physiotherapist-led adapted exercise class for people with rheumatological conditions such as arthritis or fibromyalgia, or a combination of several. It's delivered by a physiotherapist. It's free, it's online, and you get a full assessment before you participate, so that, for example, if you've had a knee replacement, you'll not be doing the same exercises that somebody that hasn't had a knee replacement, so that it's adapted for you as well. And we're currently recruiting for that. So there's a couple of programs starting. There's one in Cavan Monaghan area on the 1st of June, and there's one in Mayo on the 25th of May. They're all on arthritisireland.ie on there. And we also have a fabulous program. I think this would be speaking to Caroline as well. We have a program that's adapted by Arthritis Ireland for arthritis and people living with chronic pain. It's called Behind the Pain, but it's looking at the mental health and the emotional impact of pain on our mental health. So it's delivered by a psychotherapist in a group setting. It's free as well. And we're also recruiting for that at the moment, and it's online. It's a really fabulous program, and it's really, coming to terms with the grief, the loss of, I don't have the life expectation or the experience of life that I thought I was going to have. I've lost my friends. I've had to stop work. I've lost my hobbies. This is not what my husband or my partner signed up for. I feel like I'm a bird. All that kind of stuff that is all part of living with and dealing with and getting our heads around a long-term health condition. It was mentioned several times tonight about the Living Well. This is our core program. That's our core service. And, as I say, there's a big appetite for doing something. And, if you're on a webinar about fibromyalgia, the Living Well with Arthritis program can be a really good starting point to get into the self-management and what that actually means. We mentioned self-management quite a bit this evening, and I'm very aware that not everybody has experience of that. So the Living Well with Arthritis program is an evidence-based program. We have it running throughout the country. We were the first ones to bring it into Ireland, and it's from the SMRC. It's at Stanford Self-Management Resource Centre. It's things like goal setting, pacing ourselves, not living in the all or nothing, the boom and bust, about dealing with pain, dealing with the emotions, dealing with our mental health and depression, communication with family, communication with friends or health professionals. And this is all on the Arthritis Ireland website. You're going to get an email after the webinar, probably tomorrow, with links straight in with more information on how you can book onto these programs. So just to let you know that. As I say, there's quite a few of these programs starting throughout June. There's morning classes. There's the ones at 6 or 7 in the evening as well, which is just, trying to be as accessible for as many people as possible. And just to mention as well that Arthritis Ireland has a branch network around the country. We haven't as many branches as we used to have. I saw somebody in the comments saying they're in Donegal. We used to have a very active Donegal branch, but unfortunately it's closed. But we're always looking at setting up more branches, but tuning into some of the programs online first could get you links, get you supports, get that social contact with other people that are living with long-term conditions. As I say, the local branch network, all the information is on our website about the branches, of who and what and where they are and what they're doing. Different branches have various activities. It might be social events, information talks, support activities, different seated exercise. A lot of them are free, and there's walking groups and whatever. So that's just to let you know some of the services that we can and do provide for people. And, as I say, I just think it's wonderful to see so many people on a Thursday night at a webinar. And, as I say, I didn't want to leave everybody high and dry after tonight's talk, that, that there is a next step. And the next step, a good start, is the website. And, that Peter's here. Peter's our services support coordinator, and he, if you don't mind me saying, Peter lives with several conditions, including fibromyalgia. And so we do know what it's like, and Peter's great, practical support and advice and information, and he runs our volunteers on the peer helpline. So you're getting great reception there, Peter. And, I know that the team are really passionate about supporting people. And, that's where I say lean into us, use the website, use the booklets, use the information. And, certainly after so much enthusiasm about tonight, I think we certainly will be looking at putting on another event, probably in September time. And for now, I just want to really thank our three speakers. I thank you, Dorcas, Louise, and Caroline, for your information and your enthusiasm and expertise. And, it was brilliant to hear the whole, the information around the medical side of, the causes, how it works, how it impacts us, going into the, the female health perspective, and then going to the head and the trauma and the mind and how it impacts us. Is just, it was really interesting. And I hope everybody had that experience, that it sort of joined the dots for them, and, that it made sense for you. I see there's loads of comments coming up. So thank you all for your input as well. Really sorry, I didn't get to everybody's questions and answers, but as I say, this is going to be, the recording is going to be on the website probably tomorrow. And so if you need anything from that, please contact us. That's what we're here for. So if everybody's happy enough, I'm going to bring the webinar to a close. And as I say, thank you all so much for your attendance tonight, because we wouldn't be doing this without you. So thank you as well. And thank you for, bringing it to life as well. Thank you. Okay. So good night, everybody. And as I say, hopefully we'll see you on some of our programs on the helpline. Thank you.